being here on a sunny Thursday evening with us. We are SNaHP-UW, we stand for Students for a National Health Program. And today we're going to just talk about our theme of today is moving toward the single health care system. And just a little about SNaP here. It's a student-run organization, mostly composed of undergraduate students and medical students, or students pursuing careers in the healthcare field. And we hold events on campus that inform students on campus and off campus about the current U.S. healthcare system, as well as other healthcare systems around the world. And we just want other people to know what they're kind of getting into their future, because they're the future of America. So, I guess John will take a look in here.
Thanks, Tina. So my name is John. I'm a researcher at the University of Washington School of Medicine and the School of Public Health, as well as a community organizer with Students for a National Health Program and Physicians for a National Health Program. So we're here tonight because we at SNaP and PNHP feel that there are far too many people in this country who don't yet understand what single-payer healthcare exactly is, despite the growing buzz around healthcare reform and talks of universal healthcare. In addition, our country has reached, we feel, a critical point where millions of Americans are going without medical coverage, costs are skyrocketing, bankrupting some families who pay for their loved ones' medical bills, and easily treatable diseases are turning into death sentences for some as they delay seeking medical treatment, and they're sometimes outright refused by their insurance providers. Our focus tonight is to educate the community on what single-payer health system is, what bills have been introduced, and how to get involved in advocacy efforts. How our communities are affected by the current healthcare system, the economic impact of the U.S. health system, as well as a personal perspective from a physician working in the field. With these panelists, we aim to bridge the knowledge gap between the populace and the professionals, to spur people to action, and to encourage people to join us in the fight for universal health coverage. We at SNaP and PNHP wholeheartedly believe that no person should go without health care, and that health is a human right. So without much further introduction, I would like to invite Dr. David McLanahan up to speak. Dr. McLanahan is Surgeon Emeritus of the Pacific Medical Centers, a nonprofit public trust-controlled medical center supported by UW School of Medicine. He's also a clinical associate professor emeritus at the UW School of Medicine, where he worked for over 25 years with UW medical students and residents. In 2005, along with Drs. Hugh Foy and Erica Goldstein, David co-founded the Western Washington chapter of Physicians for a National Health Program. So please join me in welcoming Dr. McLanahan.
Okay, so see my friend Katz here, and he gives very wonderful, humorous talks. So I figured I better start off by.
You might not be hearing in the back.
You have to stand in front of the microphone, dude.
Let me try this one. Is this better?
Yes.
Okay, so I figured I better start out with something semi-humorous, just to, normally I'm a fairly boring speaker. But anyway, you may mention to being co-founder of the Physicians for a National Health Program, the Western Washington chapter. A guy named Quentin Young was instrumental in that when Hugh Foy and I went to Cuba with him on a medical delegation in 2005. While we were down there, he says, Seattle's such a notorious Soviet Republic of Seattle. Why don't you have a Physicians for a National Health Program chapter? So when Hugh and I got back, we enlisted Erica Goldstein, and we started the chapter in 2005. And ever since then, we've had monthly meetings at the Swedish Cherry Hill campus. Have a yearly annual public meeting, which we usually do at King Hall. So Quentin Young was on the trip. He's really the icon for single payer in this country, probably the most revered health rights person in the last century, half century, starting in the late 50s and 60s with the civil rights movement. He started the Healthcare Medical Committee for Human Rights, went down south, was Martin Luther King's doctor when he was in Chicago, and for 25 years or so he was the national coordinator for PNHP. So we were lucky to have him here 2 times for our annual public meeting, and you and I got to know him well. So here's a tale he always told. He was an indefatigable optimist, thinking that, well, single payer is going to happen in my lifetime. But unfortunately, he passed away around 90, and we're still there. So he told this story that he knew of a single payer advocate who was working tirelessly for his whole life and wanted to see it just like Clinton in his lifetime, but it didn't happen. So when he went to heaven, he arrived at the pearly gates and says, I would like to ask God a question. And St. Peter says, well, we'll see. So a few minutes later, he was let in. He went through the pearly gates, saw God. He says, God, is single payer healthcare ever going to happen in the United States? And God says, why, yes, yes, but not in my lifetime. Okay, well, leading off, my job is to keep it simple and in 10 minutes describe what a good healthcare system looks like, how ours doesn't measure up, and the nuts and bolts of a single payer system. So I'm not going to talk about some of the thorny issues that us single payer advocates are now dealing with. Basically, whether the only way we're going to get to where we all want to be is through an incremental approach, or whether we should try to do it all at once. That's one big thing that's been dividing our forces since the ACA in 2009. Then the question of should we be working on single payer at the national level or the state level or both? And then if we're working on the state level, should we get behind healthcare's human right, Washington's Washington Health Security Trust? What about the initiative that Washington is putting forward, I-1600? So there's people who are debating around that and hopefully trying not to get too divided. I'm not going to be talking about whether, politics, whether single payer is feasible at this time. That's a whole different subject, but I think other people may be talking about it, and we definitely should get into that in the question and answers session. So, social determinants of health, you all know about these, and there are social justice organizations working on all these issues that all have something to do with healthcare. So the only way we're going to get there with all of these issues is to work together in the movement of movements, and that's what we've been trying to do for the last few years, to get everybody together, and that's the only way we're going to change the political culture in this country. So I'm going to be talking about access to quality health care. So what do we want in our health care? Easy access. Everybody wants easy access. We want insurance to cover all the services needed, high quality care, affordable. We're worried about increasing premium, high deductible plans that are rolling out there. Cost sharing is going up, and of course the cost of drugs. We want to be able to choose a doctor or other provider or hospital that we want to go to. Basically, we want to be able to go to sleep at night and not worry that a healthcare problem in ourselves or our family is going to destroy our family's future, health-wise and economically. So what are the principles of a good healthcare system? Number one, always come back to this: no barriers to care. That's the most important thing in our healthcare system. Everybody's covered, equitable, and comprehensive. Premiums are based on the ability to pay. People choose their own providers. Sufficient providers who guarantee timely access. You don't want to have to get in your car and drive 200 miles to see a doctor or, be treated in a hospital. Focus on preventive care, early intervention, and coordinated care, where all of the people involved in taking care of you speak with each other very easily. Simple funding and payment system, adequate and timely payments to keep the providers happy. Reduce costs by cutting administrative expenses and bureaucracy rather than cutting back on healthcare to make savings. We want to keep our quality medical education, hopefully give our medical students a break so they don't come out of there with $250,000 in education loans, and research and technology. So what's wrong with our system? Access, cost, quality, equity, choice of insurance, and efficiency. Basically, they're all screwed up. So, barriers to care. If we look at the uninsured all year over the last 80 years or whatever it goes out to here, Medicare and Medicaid made a big drop in the early 70s, but then it crept back up, and then there was another drop when the ACA was implemented in 2014, but then it leveled off, and it is starting to creep back up again. So what if you're not insured? Well, basically you don't have a usual source of care unless it's the emergency room. You postpone your care because of the cost that you're worried about. People go without care altogether because of cost, and avoid getting prescriptions and other things that their doctor, if they see a doctor, advises them to do. So effects of being underinsured, this is a huge problem. You say, well, 80, 90% of people or whatever it is have health insurance, but 35% of those now are underinsured, and there's a definition for that I won't get into. But basically it means you have insurance, but if you ever need to use it, you're going to find out that it's very skimpy, and you're going to probably drain all of your savings. And this is a reason why medical debt is the #1 cause of personal bankruptcy. 75% of people who went bankrupt for medical debt actually had health insurance, so it shows you how good it is. So what's wrong with our system again? Costs were twice as high as other industrialized countries. U.S. patients get more care than these other countries because of cost. Quality, we're behind other industrialized nations, of something like 34th or something in the World Health Organization rankings a few years ago. Our life expectancy is below these other comparable countries, and I saw in the paper today that for the 3rd straight year our life expectancy is predicted to go down this year. Here's a couple of shocking things. Highest infant mortality and maternal mortality rates in the developed world. Equity. Here's mortality rates among black kids is quite a bit higher than other ethnicities. Here's another really shocking thing, that black women die in childbirth more than three times as much as white women. And black Americans die younger than other ethnicities. So where do we go from here? Basically, we can continue on the same track that we're going on. We can tweak the Affordable Care Act. This is what our Democratic politicians want to do. Some of them are introducing kind of fake Medicare programs that basically don't change the underlying system, but they would allow people to buy into Medicare, which would basically not be a single payer system, because the hospitals and doctors and everybody else would try to still have all these other insurance companies to deal with, so that wouldn't be a single payer. But you're seeing those, at least 3 of them being thrown out there because politicians are hearing from their people in their districts that they really do want them to do something to solve this problem. So they're saying, well, this is what we can do, it's realistic, so this is a step towards where we need to go. But basically, it's still continuing with the private insurance-based system. The only variable on that one that I might be interested in would be if Medicare lowered its age and everybody was automatically in it, not opt-in. Because opt-in would, raise a bunch of problems that we'll talk about later. And there's Hugh Foy.
McLanahan, all right.
So, did I praise him before I mentioned?
Sort of.
Girl,
He took all the credit.
So, where do we go from here? We can continue the way we're going, but not transforming the system. The Trump-Ryan plan, that was so heinous that even progressives bound together to fight that one. And stopped it, and it's not likely to rear its ugly head again, but there are still people nibbling around trying to privatize. So, this is our current system again. Continuing with, we're seeing a rise in number of uninsured in the last year or two. Percent of adults under Medicare age who are underinsured is 28%. According to this, there's different ways of, you see these numbers is 25% to 35%. Maybe Aaron can bring us up to date on what the best number is there. Administrative costs are rising fast since the ACA's passage. Now, private insurance overhead is rising 7% a year on an annual basis. And total healthcare spending 4.5% a year. So the ACA was not able to control costs. So single payer is where we need to go to transform the system, one public plan for all. So what is it exactly? Well, it's access to, the values. Access to comprehensive health care is a human right. The right to choose one's physician is fundamental to patient autonomy. Nonprofit and corporate personal fortunes are not allowed within the system. In a democracy, the public should be able to set health policy. Of course, that means that you've got to have representatives that are going to do what their constituency wants them to do, which is a problem we have. So nuts and bolts covers everybody in, nobody out. It's comprehensive, all needed care. No tiers of care. The ACA has in its marketplace has 4 tiers of care. You get better care, it pays depending on how much money you have to go from 60% of being covered to 90%. But with single payer, everybody gets the same level of care. You get a card that can be used anywhere. The public agency processes the bills. 2, private delivery system stays the same, so your doctors would likely to be in the same place they are now, whether it be in private practice or in a group practice, in a hospital. Free choice of doctors, improved health planning. The regional health planning authority would negotiate fees and budgets. Public accountability, no investor for-profit ownership of the healthcare delivery system. And I've got a slide somewhere that shows how much our current system is taken over by for-profit interests. So you can't just change that overnight. So there's a way that can be done, phased out over a period of years. And financed through progressive taxes. So PNHP was started 32 years ago. The famous names here are Himmelstein and Wollham, who have done really landmark research throughout this period. And there's a paper back there that shows some of the research that you probably know about, but you may not have known where it came from. In 1989, they put together the physicians' proposal. I think there was 200 physicians and people who came together to put that proposal together. And John Conyers based his HR 676 on the physician's proposal, which most single-payer advocates consider the gold standard for a single-payer plan. It's now the expanded and improved Medicare for all. Village IFL is one of the main co-sponsors of that. The physician's proposal was revised in 2016. We'll get to that in the next slide. Just recently, a couple weeks ago, they put out a pharmacy reform proposal with a bunch of doctors in Canada. PNHP has 24,000 members, 40 plus chapters, and Western Washington chapter is about the fourth largest one. So here are the keys of the physician's proposal, basically kind of reiterating what a single payer plan is. Coverage universal, complete, one tier of benefits. Hospitals are paid an annual lump sum or global budget for their operating expenses. So this separates the capital costs, which would be in buying expensive new machines. They can't just go out and empire build and use some of their operating costs by cutting down on the care that their operating costs are supposed to be used for to buy these machines. They have to coordinate them with other people in their area, their region, to make sure that everybody has good access to new technology. Private insurance companies are excluded from physician's proposal and HR 676. Public accountability. Can we afford it? Well, slashing administrative waste is the way we're going to afford it. 31 cents out of every healthcare dollar spent is on administrative costs. That includes for hospitals, doctors, insurance companies, L&I, whatever. So if we could decrease those administrative costs, we could get somewhere a whole lot of money. So we need to slash those, retain our current funding that's now going into Medicare, Medicaid, CHIP, and state employees, federal employees, benefits that we are paying for through our taxes. These to be modest new taxes based on ability to pay and using the system's bargaining clout to negotiate lower drug prices and other supplies. So here's PNHP's most famous slide. So over the decades, this shows from this 40, 50 year period, the number of doctors went up about 300%, whereas the number of administrators and managers went up over 3,000%. If you look at some hospitals, there's more people keeping track of bills and Band-Aids and who has an IV and what went into it than there are nurses and beds in that hospital. Compare that with Canada, where there's like 2 or 3 people in a hospital of the same size to keep track of those. So single payer would save a whole lot of money, $476 billion just by ratcheting down the administrative fees into a single payer, and make another $116 billion on negotiating drug prices and so on. So I'm going to stop here. I won't get into the more nuts and bolts of HR 676. So PNHP was founded in 2005, and I mentioned there's a sheet deck there where you can pick up these places where you can get on our email blast list. Look at our website to see what we're doing in our YouTube channel. We try to videotape all of our monthly meetings, and we live streamed one last time, and we're going to be live streaming from now on. So if you want to have a chance to watch it, get on our email list, and the link will be there. Thank you.
Thank you so much, David, for that wonderful presentation. I'd like to next welcome Professor Aaron Katz. Aaron Katz is a principal lecturer in the Department of Health Services and Public Health here at UW, and his research includes health policy and social detriments of healthcare. So, Professor Katz.
Well, thank you, and it's good to see you all here tonight. So SNAP asked me to talk about the relationship between social determinants of health and single payer. And David showed that a slide on social determinants, but I just want to make sure we're all on the same page. How many of you know what social determinants of health means? Many, but not all. So let me just give a little context. So the term social determinants of health, which I hate, by the way, it sounds like we all go to tea and sort of talk socially about things. It basically means the fundamental factors that make a community healthy or not. You think about where you live, your family life, your neighborhood, your community, your city, your state, and you think about the factors that affect whether your community is healthy or not so healthy. And you could probably come up with some ideas about what those factors are. Some estimates have been made about the different of those factors that build up to the health of a community. And roughly speaking, best information I've seen suggests that 90% of what makes us healthy as a community are things like education, a healthy environment, clean water, a safe food supply, whether we have good jobs and adequate income. About 10% of what makes us healthy is what happens in the institution down the hall. Okay? So, and it's not that hospitals and doctors aren't important, because of course they're important. You know, we don't want Harborview to go away. That would be a bad thing for us. But the data that David showed, most of, not all of them, but most of the data that suggested, for example, that we don't live as long as other developed countries, has very little to do with our medical care system. It has very little to do with whether we have a single payer system or not, except for one factor, which I'm gonna focus on. But I think it's important for us to understand there may be some really good reasons, and there are really good reasons, to have a single payer system rather than the mess that we have now. But one of those reasons is not that it will solve the problems of social determinants of health. It's not, a single payer system is not going to undermine the institutional racism. It's not going to change the inequities in income and wealth in this country. It's not going to assure that there's affordable housing in Seattle. It's not going to do any of those things. So I think it's really important for us to be clear about why we want to move towards a single payer. So there is one reason that is related to social determinants of health, and that is the money. So David talked about how expensive our system is. We actually, you didn't show this slide, but I think it's much easier to understand why our fragmented system costs so much. If you compare how much we spend publicly in this country on healthcare, so set aside all the private money, which is about 45% of the money in the system. So if you just look at the public money, we spend enough money for a public system just with that money. We spend as much money publicly as the next most expensive public system. So there's enough money in the system. Okay? But that increment, David, you said 31% was administrative, whatever it is very important. We spend $3 trillion a year on medical care. I think it's 3.2 now. $3.2 trillion a year on medical care. Okay? If we ever want to solve housing problems, homelessness, make sure people have make sure we have a good public education system from K to 16, If we want, what? Yeah. You having a heart attack? Yeah. If we want to be able to make the investments in the social determinants of health, we have got to reform the medical care system, because that's where the money is. Okay, yeah, the money's in the military too, for sure. But just thinking about the health sector, that if we want to, I mean, we could easily adequately fund K through 12 education in this state and resolve the McLead decision. We could go back to the 1950s and make sure that every kid in Washington state could get a free higher education at our public universities. Easily, we could do all of that if we had a single payer system. So I just want to, so that's critical for us to understand, that having a single payer is not going to solve all those problems, but grabbing the money will be helpful in doing so. As we know in this town, that we debate whether to tax Amazon a little bit to fund some affordable housing. There's plenty of money in the American healthcare system for all of that if we were able to rationalize the system. And last point I would make about the relationship between single payer and social determinants. If you look at all those other countries that have longer lengths of life, less inequity in their societies, etc., it wasn't the healthcare system that came first. It wasn't the healthcare system that led a more equitable society. It was political decisions and political movements for more equitable society that led to or formed the basis of healthcare reform. Whether you're talking about, I mean, the German system, which was created by Bismarck in order to push off the growing labor movement, whichever system you're looking at, single payer or healthcare reform didn't lead, it followed. So it's usually a product of a more equitable society, which is another reason for us to work on all those other determinants of health. Thank you.
Next, I would like to introduce Bevin McLead. Bevin is the Program Director for Healthcare for All Washington, which is a nonprofit organization fighting for Washington State single-payer bills since 1990. Healthcare for All Washington was founded on the principle that all residents, no matter what their socioeconomic standing, should have access to affordable, quality, publicly funded, and comprehensive healthcare. Bevin has a diverse background in nonprofit, advocacy, and campaign management. She's passionate about equity, equality, social justice, and human rights issues. So please join me in welcoming Bevin.
I see a lot of familiar faces in the audience. Thank you, everybody, for being here. I am going to be pretty quick about this, but I've been asked to kind of give an overview of what is happening at the policy level, both at the national level and then at the state level. And as John said, Healthcare for All Washington has been pursuing the legislative route here in the state of Washington for a number of years now. So first want to talk about what's happening at our congressional level. I think probably there are some folks in the room who are pretty well-versed and savvy in terms of what's going on right now. As many of you know, Senator Bernie Sanders submitted a bill this past year calling for a single-payer healthcare system. And these are just kind of some pieces of what the bill is calling for. Basically a 4-year timeline. Year one is changing the age for Medicare for all, or excuse me, for Medicare, bringing in some new folks as well as children up to age 18. Year two, eligibility is lowered to 45, et cetera, you guys can read. So these are the components that Bernie is calling for in his bill, which include essentially all comprehensive medically necessary components that folks need in terms of visits to the hospital, visits to primary care, dental, vision, etc. I would like to kind of just bring your attention a little bit to the names that are at the top of the co-sponsor list. Does anybody see anybody from Washington there?
No.
So that is one big piece, I think, that all of us can work on, is really asking our senators in the state of Washington to sign on to this bill. So we have two incredible women in the Senate, and I think that they could really sign on to this, and that would take us a long way. Wanted to also talk about HR 676, which is expanded and improved Medicare for all. Prime sponsor, Representative John Conyers, and co-sponsors, Jayapal and Smith, along with 120 other representatives in our Congress, in our state House of Representatives. So this would be kind of not on a 4-year rollout, but essentially immediately expanding Medicare to include all residents of the United States of America. Comprehensive coverage would include everything that you see on this list here. And I think that this is probably really, at least what I've heard, most single-payer advocates are really pushing for HR 676 and really see this as kind of the gold standard for a single-payer system, which we actually have a couple single-payer systems in the United States already. Medicare is one of them. The VA is another. So we have an idea, at least, of what something like a single-payer system would look like. We just haven't expanded it to everybody yet. So what's happening here in Washington State? There have been a few bills that have been submitted this last legislative session especially. This first one was submitted by Senator Marilyn Chase, kind of at the very end of the legislative session. She dropped it without telling any of her colleagues, which was kind of funny. But the composition is essentially a volunteer board which puts together a citizens advisory committee which consists of 22 individuals. And I would urge folks who are interested to go to the Washington State Gov website and pull up the bill and take a look at all of those 22 people because it's multiple different folks from different areas of healthcare. Eligibility is all Washington State residents, and comprehensive coverage includes all medically necessary care, which pulls from the lists that I had previously, and then long-term care to be incorporated over time at the direction of the board. So in the body of her bill, what she's asking the board to do is essentially come up with some ideas around how we might incorporate long-term care in the state of Washington. But there's no time limit to it, at least in this iteration of the bill. It's there, we should do it at some time. SB 5701 and HB 1026 are the two bills that Healthcare for All Washington had submitted this last biennium. And what it does is it establishes the Washington Health Security Trust. Senator Frocht and Representative Appleton were the prime sponsors this last biennium, and it's looking like Representative McLead will be the prime sponsor in the House next year. And you can see the different co-sponsors on these two bills, which I would say are the most out of any of the state bills that were submitted, but we have a lot of work to do, for sure. So if anybody doesn't see their legislator on this list of co-sponsors, feel free to give them a nudge. So the composition of the Washington Health Security Trust, briefly, is a Citizens Advisory Committee, a Technical Advisory Committee, and a Financial Advisory Committee. Working together, I think it's pretty self-explanatory. The Technical Advisory Committee would determine exactly what procedures would be covered, but the idea is that it's very similar to everything that you guys saw previously in terms of medically necessary comprehensive care. The Financial Advisory Committee is there to make sure that that cost sharing is going down as much as possible, that the procedures that are needed are covered equitably, that if there are any changes in those criteria, that they're figuring out how to pay for it, and back and forth. And then a Citizens Advisory, making sure that the citizens' voices are heard also within the trust. Eligibility, of course, is all Washington State residents, and I want to highlight that throughout all of this, that's regardless of immigration status. This goes for all of those listed here. And then comprehensive coverage includes So there was, similar to Chase's bill, not there at the get-go, but brought in after a certain amount of time. So it looks like the bottom part had a little wonky switching through files, but wanted to say that Senate Bill 5747, which was primed by Senator Hasagawa, is verbatim the same as these two, except that he adds a section with financing from existing revenue sources. So another thing that's happening here in Washington State is that there's a ballot initiative being championed. They're hoping to get enough signatures to get it to the ballot for 2018, and they're collecting signatures. I think I saw a couple of representatives. Yay! There you go, in the back. So if you guys want to sign their petition, please do. And very much structured on the basis of the bills that Healthcare for All submitted, with exact same thing, except that they have incorporated a financing mechanism into their ballot initiative. And so that directs the state in terms of how to fund this, how to cover, and they also have incorporated dental, vision, and long-term care immediately. So going back to the U.S. Congress, I wanted to touch briefly on how do we get this funded at the state level. It can be complicated because, especially in Washington State, we are the most regressive tax system in the United States, in our state. And so we have our hands tied in terms of funding, but a lot of, all states do in general, because we still have federal funds that come into our state that help with our Medicaid program and our Medicare programs and so on. So how it works right now is that if a state wanted to do a single payer system, they would have to apply for waivers at the federal level under Section 1332 of the ACA, which I think we can all agree with this administration would be a hard thing to do. So what is happening right now is that Pramila Jayapal is working on a piece of legislation that she is hoping to introduce probably the first week of July that would help to address the situation for states. And I understand that some representatives from her office were invited, and I know that I think they couldn't be here tonight. But I've been working closely with their office on the language for this and on getting it rolled out. So essentially what it would do is replace the existing Section 1332 with a provision that if a state could demonstrate that within 5 years they're going to cover at least 95% of the residents in their state, they would get this provision, and so they would have the federal funds coming into their state. So again, this would not be a mandate on states, but this would be an option for states who want to go to a single payer system. So this is kind of an answer, we hope, at the federal level to what's tying a lot of states' hands right now, and has certainly tied our state's hands significantly in talking to our legislators in the state of Washington, where many of them convinced that we can't do it without these federal funds, and so they haven't really been pushing it forward and championing a single-payer system in Washington State because they don't see it as viable or doable. So this is an answer to that, and so I would urge everybody, once this bill goes out, to really push on our other congressional delegates in the state of Washington to sign on to Pramila's bill, and so that we can get this through. So here are some resources to some websites, including all of the organizations I think that have been mentioned today. And so I would just like to urge everybody in the audience to get involved somewhere, whether it's volunteering with Washington and getting the petition signed and trying to get it to the ballot, whether you want to come volunteer or with Healthcare for All, whether you want to join David McLanahan with PNHP, or John with SNAP, please do so. And I am happy to answer questions later, and I have some cards.
Dr. Basu is a health economist and statistician and also a professor in the Department of Health Economics and Department of Pharmacy at UW. His research includes revealing heterogeneity in clinical and economic outcomes and studying the value of individualized care. So please join me in welcoming Dr. Misty.
First, let me thank you for inviting me to present. This is a great discussion we are having today. I'm going to take some time to really talk about some of the issues that we face in moving towards a national healthcare system. Obviously, some of these data are already covered by the previous speaker, but it would be good to actually kind of review some of these. So right now, in the United States, about 91% have some form of insurance, health insurance. This is in 2016, so this is post-ACA. A majority of that is driven by employer-sponsored insurance. And if you remember, the employer-sponsored insurance started after kind of World War II, when health insurance was taking up, and the government actually subsidized employers to actually offer health insurance to those folks. Here you have about the non-group insurance, which is the individual market. The Medicaid is about 19%, Medicare about 14%, and there are some other insurance. So this 9% is really the uninsured who do not have any insurance. Now, that's not to say that these people have full insurance, as David pointed out. Some of them have underinsurance in these markets. To break it down by age group, if we see, obviously, among the elderly, almost 99% have insurance through Medicare. There's still 1% who do not have insurance under Medicare. And part of the reason is that Medicare still asks for a premium. And there are some people who would not pay that premium or cannot afford to pay that premium. And so there's still 1% insured. Among kids, there are about 5% uninsured. And most of the uninsured people are in this age group, 19 to 64. Obviously, 65% of the population is also in this age group. So it creates a lot of inequity in kind of healthcare access. So when we are thinking about national health insurance, obviously we are trying to shift a lot of that insurance that exists today towards more government coverage. But mostly we are talking about these two groups in kind of providing access to those kind of access to healthcare through a national insurance system. Now, it's important to understand that under the current system, there are a lot of problems with insurance, and that is why we are having the discussion about national health insurance. We talked about access and undercoverage. We have a private system which is often problematic because of adverse selection. That people who are not healthy are more likely to buy insurance, and that jacks up the average cost of insurance, and that jacks up premium, and the insurance product actually goes out of the market. The ACA had a lot of rules to prevent adverse selection. One of them was individual mandate, which obviously had all sorts of problems against it, and kind of push back against such a provision. There is other aspects of the current healthcare system which we did not talk about. One is underinvestments, and the idea is that in other countries that have national health insurance, if you have a technology, a healthcare, a medical care that has a high cost, upfront cost, you still pay for it because you reap the benefits over the lifetime of the patient. So Valdi for Hep C was a classic example of that. In this country, because everybody transitioned at 65 to Medicaid, which is a public insurance system, private insurance systems often do not have the incentive to pay for hundreds of thousands of dollars when you're 50 or 55, because they are not going to rip any of those benefits or cost saving from that drop. And so as a result, there's a classic underinvestment that happens because there is no uniform lifetime perspective that would allow them to invest in health upfront, so that the health benefits can offer over a lifetime. There is also this paradoxical effect of competition. The idea that often people think that because it's a private system, it's a marketplace. Insurance products compete with each other, and because competition is good, it brings down the price, which works for many healthcare, many consumer products. The problem with insurance, health insurance though, is that while it can help decrease some of the costs of overheads because they have to survive in this, what they lose in a competitive market is the negotiation power. Right? Because as markets become more competitive, health insurance becomes smaller. As health insurance becomes smaller, they don't have enough leverage to demand a good price. And as a result, the paradoxical effect of competition actually kind of brings up price. If you look at, there's a large literature on cost variation in this country. Miami charges so much more for the same procedure as Seattle, right? And if you see that variation, much of the variation in the private sector is driven by prices, whereas much of the variation in the public sector is driven by actually what you're doing, because prices has been equated across the country. So these kind of things point out that obviously we should think about national health insurance system. We should go about it. But let me give a caveat, and I would go back to David's point that he started with. That I don't see, given the current status, that we would see national insurance in my lifetime, or I don't know, my son's lifetime. And the reason is purely one, and that is healthcare expenditures. This is the growth of healthcare expenditures in the country since 1980. And Austin Frack, who's a very well-known economist from Boston University, had this blog about 1980, the paradox of 1980. What happened? Nobody knows what happened in 1980. If you look, there was some graph before that, and all the healthcare expenditure in the country was moving quite along. And then something happened in 1980, and the US kind of took off. And by now, in 2013, and this is dated, US is about 16% of the GDP, and right now it's about 18% of the GDP. Right? Which, as Alan said, is about $3.3 trillion a year. But let's look at the breakdown of that. So here you have the breakdown of the public and the private. The public accounts for about 1.5 trillion of that, and the private sector accounts for 1.8 trillion. And among the private sector, the cost is borne by households, the premium they pay, the out-of-pocket costs they pay, by businesses, the employers, they pay for most of the premium that you get healthcare. And many other private entities. So what we are thinking of, if anything, nothing changes today, and we want healthcare, national health insurance, is government taking over this part of the pie and providing health insurance, which is government accounting for $1.8 trillion a year, above what they're spending right now. So let's see how they can get that. So one idea said, well, you can cut other funding and move in some of the funding to government to provide national health insurance. Well, this is the graph of kind of the US investment in healthcare, which is 16%, and social care. Aaron talked about social determinants of health. And social determinants of health investments comes from social care. And as you can see, US is one of the lowest that funds social care, that has public investment in social care. It's about 9% of the GDP. If US were to get $1.8 trillion, they have to cut the entire social care budget, which is 9%. $8.1 trillion is about 9% of the GDP. That's not going to happen. What about taxes? We talk about, let's raise taxes to get $1.8 trillion, right? Here are the total private income tax from various countries, from various years. By 2018, the total income tax collected in the United States is about $1.8 trillion, which means you have to double your income tax to collect that $1.8 trillion. So you can actually say, well, you don't have to do one thing. You can mix up. You can do various things together. And Bernie Sanders' plan, Medicare for All, is that plan. But that plan does include a 6.2% interest on progressive income tax raise, tax on capital tax gains, and many other things. and still it doesn't cover the $1.8 trillion. A part of that, at least 1/3 of it, is based on the idea that if we do a national healthcare system, we would generate savings. How? Well, we could negotiate prices, we could bring down administrative costs, and that would save about $600 billion a year. But let me ask you, currently 40% of the US healthcare is public. Do they do any of these things?
Yes.
Do they negotiate prices? They don't negotiate
Yes,
prices.
they do.
Only in VA?
The VA does.
CMS does not negotiate prices. They do not. They can by law, right? They are not even asked, they are not even by law allowed to look at costs when they cover benefits, right? And so if you think about, we want to do a national healthcare system and say if you do the national healthcare system, all these things would happen. But it's not happening now. So what would give you the leap of faith that if we expand national health insurance system, all those things will happen, right? But, so my main point is that, and again, I'm a pro-national health insurance guy, but I'm a pragmatic national health insurance guy. And so what my point is that national insurance system in the US is unlikely to happen unless we are able to reduce healthcare expenditure overall. When you have 18% of the GDP submitted to healthcare expenditure, and 60% of them is the private sector, and you want to take over that and put it in the public budget, you have a lot of issues, And so where can we do, what can we actually address before we go and try to morph the system? And there are three main areas where I think we should think about how to reduce the spending problem. One is ineffective use. There's a lot of waste in the public, in the healthcare system. We are doing things that really does not give us benefits. They actually sometimes harm people. We are paying for treatment that extends life by 1 month, and we are spending billions of dollars on that. Now, if we take the patient perspective, that 1 month may mean tremendous amount of value. Right? But that 1 month costs something which can save thousands or hundreds of years for other patient population. By law, we are not allowed to look at that. We are not allowed to say that, this is the drug that is cost effective, or this is the treatment that is cost effective. We have bundle payments, we have episodes of care in the system that would rein in costs, and kind of say that this is the cost that I'm going to provide our providers to do certain kind of treatments. But we have made it voluntary. Not every provider are allowed to enroll in those bundle payments. In fact, the Prof administration has eliminated most of the bundle payment systems at this point and asked to rethink. But think about prices. Are the prices worth it? Are the drugs that we are paying for, really worth the benefit that we are getting? Our institute is involved in the first collaboration with a non-profit organization called ICER, Institute for Clinical Evaluation Research. They provide cost effectiveness of drugs and put it out in the market. And most of that information is taken by private payers, and they are used to negotiate price down. CMS wouldn't look at it, because by law, they are not allowed to look at costs. And obviously, it was pointed out, administrative cost is about 25%. Administrative costs in this country is more than double the healthcare expenditure we spend on cardiovascular diseases. It's more than triple we spend on cancer. So obviously, you would think that, well, if you go to the national healthcare system, it's going to reduce administrative cost. But let's, as an economist, it gives me pause. Yes, CMS has slightly lower administrative cost than the private payer system, right? But the CMS piggybacks a lot of the administrative costs on Social Security. There are other tax that has been imposed to get to the national payer system. It has cost implications, administrative cost implications outside healthcare, in the tax revenue system. So to what extent you can assume that $600 billion would be reduced just by moving to a public insurance system is a little, the evidence is not clear. Now what we can do subtly is through IT and through other processes, it is possible that we could actually look at it and see why such waste is happening, and we could bring down the overall administrative cost down. You know,
Is it Medicare? Is that administrative cost 2.7 to 3%?
I think what Dan showed was about 5 to 6%, and private payer was 7 to 8%.
The stuff that I read said 3%, but yeah, maybe. But even then, and then I thought under Obamacare, because you have the 2080 rule anyway. So
Well, 2080 is for individual market, by the way. The individual market 20% is then you have to pay back or something like that. And that's an individual market is like a bizarre, because there are so many other things that's going on in the individual market. Who knows, right? But in the employer sponsored, which is kind of the 50% of the market, you know, the administrative cost, I don't know, it's about what your slide said was about 7-8%, and then you have Medicare 3-4%, right?
yeah, Medicare is that low.
Maybe we could hold the questions until we're done with the presentations.
Okay. Thank you. No, just relevant to.
So my point is simple. You know, the point is that we are spending 18% of our GDP in healthcare. If you cannot reduce the costs overall, it is a very difficult transition into having the public money take over the entire healthcare system. And the question about, well, we should move to the public system and that will reduce money. Well, that certainly is possible. But if you look at the evidence, what's happening within the public care system that exists today, you know, it doesn't seem promising. And so I think if we were to kind of promote and kind of lobby for national healthcare system, we should be also lobbying that our public system right now should think about cost, should actually negotiate prices, and should bring these things down before we can actually strongly promote the movement to the national care system. All right, thank you.
Dr. Christopher Wong is an associate professor in the Division of General Internal Medicine at the University of Washington and practices at UW Medical Center. Dr. Wong's clinical interests include preventative health, hyperlipidemia, and ambulatory care transitions. He has over 17 years of experience in the field of medicine. So please join me in welcoming Dr. Basu.
Thank you. Wonderful. So yeah, like I said, I'm Chris Wong. I work in the Roosevelt Clinic, which is up the street. I do primary care just about every day, and I do a little bit of work down this hallway. This is actually where we do our chief of medicine rounds on Tuesdays. So I want to thank the organizers from SNaP for inviting me. Full disclosure, they were asking Eric Lamont, one of our amazing hospitalists, but he couldn't do it. So I'm talking about primary care, and I think this is the touchy-feely part, because I'm not a researcher and I'm not one of the leaders in PNHP. I've been a member for years, but I still a member. But I want to talk to you about, they asked me to talk about a little bit of what goes on in the clinic. So how many of you here are clinicians? Let's see. Okay, primary care, anybody? Nice, maybe some surgeons, that's great. In non-medical types, anyone completely different fields? Great. And then students, I know, right? There's some medical students running around in undergrads and also students. Okay, great. So, first of all, these views are my own. I work for UW. I actually have my badge just because I'm trained to do it. Every time I walk into this building, according to Joint Commission, you need a weird badge. So sorry, but I'm actually not representing UW. I wish I were representing UW about this. These are my views. I am also a member of the Single Payer Interest Group for my academic society, which is the Society of General Internal Medicine. So, I want to talk to you about one of my patients. I could probably talk to you about any number of my patients in terms of the effects on the healthcare system. And this is even at our fancy UW clinic, right? I'm not in one of the federally qualified healthcare clinics. I'm in a university clinic, and still this happens every day. So I just picked one patient. This is Marty. That's not her real name. Marty's 60 years old. This was a few years ago. She was 60 at the time. She has diabetes, she has hypertension, and she has asthma. The younger folks in the audience probably think this is Marty. This is not Marty. Marty works as a nursing assistant. So Marty takes care of people. So what happened to her? This is what happened to Marty. She was at work. So being a nursing assistant in a nursing home is a very physical job. One of the very large residents, we have to mention, injured her hand. She had a lot of problems. She ultimately developed a pretty bad pulmonary neuropathy, and it was her dominant left hand. We went through a lot with Marty. Nerve studies, consultations, physical therapy. She tried to go back to work many times. She just ultimately couldn't do it. So you can see probably where this was headed. She finally gave up on labor and industries after 2 years. To be frank, L&I was actually pretty good initially. They really helped pay for some of these initial studies. But eventually they wanted to pose her claim, and eventually she just gave up. Do you guys know what an impairment rating is, by the way? So if you have a permanent injury, there's a percent rating that says, how impaired are you? Some of you guys are nodding down through this. So Marty, she went from basically mostly normal to not being able to use her dominant hand to do the physical work. What do you think they rated her impairment? 100% is completely impaired, 0 is you're completely normal. What do you think they gave her?
30%.
30, nice, optimistic. They gave her 1%. They gave her 1%. Like,
Oh,
they offered her a 1% impairment rating for this. Eventually she went back again, got another independent medical. They got up to 6%, and they offered her a payout. I won't tell you how much it was, but it was very small. It was so small, she actually showed me the check and says, I don't think I'm going to cash this because it's so little. She just gave up on it eventually. She became homeless. She was never on the street, fortunately. She stayed with her sister, who she didn't love, but would agree to stay with her. She had to pay for her meds. Insulin inhalers are extremely expensive. Those of you who do primary care know this. It was really difficult for her for a while. Now this isn't going to be completely grim. She got lucky. She had long-term disability insurance. Okay, so she got, and that kicked in after a period of time. So she got some other ways to get her health care. And, well, we can't see this on the slide, but what's covered up there is she got on Social Security disability, which means you can get Medicare. Right, exactly. That's the back door into Medicare if you're disabled and you paid into the system, which she did, working for, 30 years. You can get Medicare. So she got Medicare, and life started to get better. In fact, the last time couple times I saw her, she was back at vocational rehab and learning how to use PowerPoint. She was actually very excited. So it's not completely grim, but boy, what failed Marty here? Okay, did her doctor still? But what really failed her? A lot of things, right? So I would argue employer-based healthcare is a failure. She had her healthcare tied to this job. She couldn't do the job anymore. It could have been any number of reasons why she couldn't do the job anymore. This just happened to be a case where she got injured on the job. L&I actually was good, but eventually I think they didn't really help her enough, in my opinion. That's my opinion. But it's not all grim, right? What actually worked? Well, the SSDI system, the long-term disability, and she eventually got in Medicare. But how old was she when this started? 60, right? What age is Medicare? 65. So she was in a limbo for a while. And if she hadn't got this SSDI, which is Social Security Disability Insurance, she would have had many patients just sitting there waiting, like, maybe I can put off a few things till I hit 65. I don't want to buy the Affordable Care Act plans. I'm going to wait for a little bit. That's what happens to a lot of people. She was in this limbo also. So that's just the story. There's countless others. A couple other things. So that's Marty's story. There's any number of other issues. So in my day-to-day work, there are so many. I won't bore you with this because my other disclosure is that I'm actually a pretty happy doctor. I'm not one of those disgruntled people who's going to come through, everything's terrible, I hate the EMR, I'm going to retire. I'm actually pretty happy with my job. I'm lucky to work at the UW. I work with amazing students, amazing residents. But still, there's a lot of things. The drugs, we heard that. They cost too much, we can't negotiate. The patients can't negotiate. The imaging, it costs too much, right? If an MRI were $5, we wouldn't be complaining about it, right? I wouldn't be denied. Prior authorizations. Those of you who've done primary care, if you ever had to fill out a form or call to get on the phone with somebody, why do they do that? It's a barrier. They don't want us to do it, so we'll give up and ask for something, right? Metrics. We have people, Dr. Basu, who's actually studying the right things so that we are looking at the right outcomes and doing things that will head to those outcomes. But what do we get metrics on? People make this stuff up and we get graded on things that they haven't quite done the science yet. You've probably seen this, right? They have a metric, but is the science there? Maybe not yet. You could argue that physicians make too much. I think that's actually a fair argument. You can argue about exactly how much is too much. And then et cetera, et cetera. But there are so many problems. I'm not going to sit here and say, oh, everything's terrible. We know that. You guys know that. You come here to this audience. What I want to talk about is a little bit of how I feel that on a day-to-day. You saw what happened to Marty. This is kind of what gets me. So I was at a meeting recently. My national meeting, Society of General Internal Medicine. These are the really nerdy academic internists. People are like, I want to learn about teaching, research, and do all this stuff. And there are countless interventions. These are really well done research studies, amazing researchers, lots of research money, lots of grants, some government grants, and they're studying a lot of things. And some of them are quite worthy, but a lot of them, when I look at it as a kind of in the trenches, with their academic fancy trenches, taking care of my patient, when I look at that, most of them aren't trying to change it. They're not trying to find a way to control the drug costs. They're trying to find a way to make people use less. I won't say all of them, but the vast majority that I saw, yeah, basically it's like, how do we make people lose less? Have you ever heard the phrase skin in the game?
Yeah.
They want patients to have skin in the game so that they can do some kind of market thing and use stuff. I think my patient's skin is in the game, right? I really do. So, now of course, we've just heard that some of the public issues are overutilization. So that is an issue. But for some reason, it seems to have been a lot of what's dominating. So that's how I feel it. And so this is the way I look at it. This is our fair state. There's a lot of problems, right? And that's a patient there, right? You got to go get meds, you know, if you have something serious. Sometimes you do need the imaging. Sorry, guys. Sometimes you need it. Sometimes you need to go to the hospital. Sometimes you got to go to the ER. All these problems, they're all on fire, right? It's not just the drug costs, right? It's everything. Everything is too expensive. So what happens? Are we trying to put out these fires? Sort of. And I think that's Professor Basu's point. Instead of saying, let's get Medicare for all, we should also be fixing Medicare right now, right? So what happens? Patients got to do all these things, but a lot of what is trying to be done is saying, let's get them to use less. The hospital costs too much, so let's keep them out of it. Now that's not necessarily wrong. I'm not saying patients want to be in the hospital longer, but let's think about this carefully. What is the data? When should we be trying to keep them out of it? The ER costs too much, right? You've seen news stories. You show up in the ER, you get stitches, and it's $1,000. So let's keep people out of the ER. Well, why does it cost $1,000? So, but instead what we do is we're restricting things. And so basically, your patient's world gets smaller and smaller. That's what it feels like. Okay, we can't do this, we can't do that. They don't want us to do that. If I order this, somebody's going to frown on it and say, you shouldn't order that. And that's what it feels like we are doing. That's what it feels like to me when I practice in primary care. And I realize I don't have data for this. This is the touchy-feely part of it. But that's what it feels like we're doing. So we do need the smart people to figure out how do we put out those fires and not just try to restrict people to an ever smaller piece of the healthcare market. Percent GDP. I'm so glad you put that up because I don't want to see another GDP slide. No, it is obviously the smart thing to do, but it doesn't win over my heart and my mind, and I'm not sure it will win over others. So if we put up the GDP slide, which is 18% now, right? That's important for all of us. It's important for the researchers. It is important because obviously, but the GDP is not what's on fire, right? It's our patient. It doesn't even. They're not even in the game, right? They don't even have healthcare at all. So in my clinic, I just can't on a day-to-day basis feel like, oh, percent GDP. I really feel like 18% right now. I don't. But I feel that it's when people don't actually have anything or they can't pay for what they have. Obviously, it's related. I get that. So those people not in healthcare here, what else are you guys in? I'm just going to shut up. What fields are you in?
Software.
Software. What percent of the GDP do we spend on software? Does anybody know? I don't know. What else are you guys in? Anything else? You're all software. Sorry? Education. What do we spend on education? It's like 7%, right, I think? Yeah, something like that, right? But it's not a number everybody knows and everybody's worried about. Oh my gosh, we're spending too much on education. Oh my gosh, we're spending too much on computers. For some reason, we've been fixated on percent GDP. That's why I love that you guys put up the actual numbers. How many trillion, right, or 10,000 patients. That's really important. I love that you guys put that on there. But I don't think the percent GDP is the emergency. Not having coverage is an emergency. So that's the way I think of this. So when I think of winning over all the incrementalists out there, boy, there has to be the moral argument. And that is what does it for me. It may not work for everybody, but we can argue about the efficiencies. We can argue about the economics, right? We can argue about should we do, you notice nobody's saying VA for all, right? Have you heard VA for all anywhere?
Yes.
I love the VA. You have? Okay, good.
Oh, yes.
That's great. Okay, but you don't hear it that much. I argue you don't hear it that much. I love the VA. I mean, some of the work they do in ambulatory, dual diagnosis, spinal cord injury is phenomenal. They're not too bad on the VA, but if you get admitted to the hospital, do you want to be at the VA or do you want to be at the UW? Depends. I don't know. Some people do want to be at the VA. That's okay. But a lot of people don't. We talk about all these other countries with these amazing systems, right? I don't know about you. When my patients are overseas and they get admitted, the first thing they want to do is get back here, even in these supposedly good healthcare countries. So we are doing some very good things in the U.S. I don't want anyone to forget that. We are doing some amazing healthcare here, and it is the social determinants that is the name of the game for fixing the other stuff. But for me, healthcare for all, that's a moral argument. That's what wins me over. It's going to win me over every time. I hope it wins more people over. It's just the basics. Why can't we just at least, for God's sake, cover everybody? That is, for me, when I go to work on an everyday basis, what I think about. Medicare for all, I mean, I'm a member of PNHP. I'm all for it. But if you actually work in Medicare drives me nuts. They do a lot of crazy things. A lot of what I have to do is with Medicare. Now that's why I love that the platform has improved Medicare for all. But if you talk to some community docs in private practice, are they looking for more Medicare patients? Usually not. So that improved part is so key. I don't know how we can amplify the improved part. It's not very catchy.
The RBS. RBS.
Say that again?
The RBS.
RBS. Okay, we'll get to question.
Reimbursement.
Yeah, so yeah, there's a lot to be said about it. But anyway, so I think it may be tough to convince people on the evidence alone. That's what I think. But that's my opinion. That's what weighs for me is the moral argument. We just need to cover everybody. Do we need to get the social determinants of health? Yeah, that'll do way more than this. But for me, it's the moral argument. That's what I wanted to leave you with. So Marty, if we had a national health care program, I'm not going to call it health insurance necessarily. It's called health care. She would have had no insurance gaps despite her employment changes. Would it have averted her homelessness? I don't know. There are obviously other factors at work here. Speaking of premiums, I didn't put this on the slide, but she was nervous going to Medicare because she had to fork over some of the money, the little bit she was getting, to pay her Medicare premium. And obviously would not correct all the social determinants stuff at all. I'm going to stop there. I'm happy to take questions for questions.
So I think, Dr. Wong, I just want to start with you. You gave a great presentation. I just want to say thank you. And I wanted to ask you, as most people know, there are many policies that act as barriers, as you showed by all those fires on Washington State. And from your experience, what single policy would you want to see changed to have the greatest impact on the patients that you work with?
That's such an incredibly hard question. What single thing? Obviously, a progressive taxation system and fixing our social determinants of health would be the best thing. It's not going to be the one, right? So yeah, get rid of our sales tax, do progressive income tax, and actually invest in early education, invest in housing, etc. That would probably be the one thing. I would be happy with that, even if we didn't have, like, if I had to choose between that and actually a healthcare system, I probably would take that. And I think that's important to keep in mind. Other than that, I would take a national healthcare system like what PNHP is advocating. I just want to say there's a lot of other things that people are advocating. Tech innovations, right? That's going to be the best thing, right? Or personalized healthcare and value-based purchasing, all these other things. I mean, I think they're important, but they're going to be a small change compared to actually changing the system.
Thank you.
Our next question is for Professor Katz. In your view, what has been the largest impediment to implementing a single-payer system in the U.S., and how can a public health mindset be employed to overcome this mindset, and how have other countries overcome the obstacle?
Well, the single most important impediment to reforming to a single-payer system is that every dollar in the healthcare system is somebody's income or profit. That's the impediment. $3.3 trillion is somebody's income for-profit, including, by the way, folks who work in this building, researchers, healthcare providers. We all benefit from a system that hemorrhages money. So that's the impediment. A public health mindset, if we think about, if that means promoting the health and well-being of our communities and promoting equity, I suppose that would be useful, but really this is a political battle. It's not a, it's not a battle that public health is going to help to win. This is a political battle over what's right, the moral imperative that Dr. Wong spoke of.
Thank you. Our next question is for David. What are you most excited about with single payer, considering your field of expertise and your background?
The political climate seems to be changing in the past year or two. There's, just look at Congress, all the people that have signed on, more than half of the Democratic caucus has signed on to the gold standard single payer bill. Bernie has 20 or 15 co-sponsors or whatever it is. When he put a similar bill out there a few years ago, he got one. Did you get any? Just one, I think. So, and then you've got the younger generation. The millennials are going to be the largest voting group in the 2020 elections. They seem to have gotten behind Bernie Sanders and turned on to his values. And certainly one of the biggest problems that's facing everybody is healthcare costs, and can they afford healthcare for themselves and their family? So I think we've got a political climate that is going to help us with all these social determinants of health, as long as we progressives can stick together and not battle each other, which is the basically the history of progressives. So I think the political climate and the right wing is bringing us together in a way that it hasn't before. So I'm hopeful that this will continue, and maybe there'll be some changes in Congress in the coming election, and definitely 2020. I'm hoping that we'll be in a good climate for passing single payer at the national level.
So my next question is actually for both Bevin and Dr. Basu. We'll start with Bevin. So there are currently efforts to establish a single-payer system at the state and federal levels. There are some opponents who argue that efforts to establish a state single-payer bill is detracting from national efforts to establish Medicare for all. So in your opinion, where do you believe our focus should be, and is Healthcare for All Washington currently pushing for a national single-payer bill as well?
So I'll answer the last part of that first, which is that yes, absolutely, Healthcare for All is always pushing for a national healthcare system, because I think that ultimately, in terms of cost savings and efficiency and so on, that's going to be the best way to go. I think that that's pretty evident. That said, in terms of, as David was mentioning, the political climate, I think that it's an uphill battle nationally, and we, at least the two congressional delegates that we have who have signed on to the national bills, have both said to us, we need you to keep pushing at the state level, because we're not going to get anything passed nationally until we have a model at the state level that we can use to point to that shows that something can work. So, yes and yes, altogether. I don't think that it detracts, in the sense that what it does is it offers another conversation piece. It offers yet another education component for a state legislature. Even if we try again in 2019 and we don't get it through the legislature, that many more legislators will have been educated on what a single payer system could look like in Washington State. That many more constituents could have had the conversation and be spoken to about what a single payer system could look like. And so the education component is incredibly important. So I would also just finally say that that's how it started in Canada, was in Saskatchewan province at the state level, essentially. And it's still administered provincially in Canada, even though it's a nationwide system. So I would say that Each country, each state does it their own way, but it's one of the ways that we do things in the United States. So,
Thank you. Professor Basu.
Yeah, I mean, I would say, healthcare for all at the national level is the goal, is the final goal, and we should work towards that. I mean, it's very admirable that the Washington State is actually trying to do healthcare for all here. And one of the unintended consequences of a state level national health insurance or state level universal health insurance is the undue burden it poses on the state resources when your surrounding states do not have universal health insurance, and to what extent that would create an inflow of patients and of different severity level within the state is unclear. We didn't have the system, or we don't have the evidence on that, but that's something to consider. But so my guess would be, if we can, we should definitely go for national healthcare for all.
Great. So now we'd like to open it up to the general audience for Q&A. So are there any questions?
Let's see, physician, Dr. Katz, can you give an example of how, Can I have a physician give an example of how evidence-based care would be more supported by a national system?
There's only 2 physicians on this panel. So one of you has to speak. One doesn't practice it.
Dr. Wong?
All right, I'll take.
Yeah.
Again, I'm not a researcher. It's all how you do it, right? So we have a national system. It's Medicare. So does Medicare practice evidence-based medicine? I might turn to some of my esteemed colleagues here to answer that question. They do a lot of demonstration projects, and then they try to incentivize, right? But sometimes they're a little ahead of the game, and they haven't quite figured it out. So I'll give you one example: is the Medicare readmissions program. So about 20%, I think, is the rate of readmissions for Medicare patients, and I worked on this here at the hospital for a while. And quite frankly, I didn't succeed. It's really, really difficult. And so they set goals to reduce readmissions, and it was basically on a curve. And which the way they graded hospitals across the country on Medicare. And if you didn't improve, well, you got penalized, and that means they paid you less for what they paid you for in Durham. The problem is we didn't have the science on how to actually do it yet. We didn't quite know how to reduce readmissions. There's a lot of gaming of the system in other places. And it created another bureaucracy. People had to figure out if they got the coding right on the inpatient, or the outpatient, or the observation, how, what's the level of complexity. So it created this whole other, probably, I would think, unintended consequence. And I don't think they've quite solved the problem yet. So I would say it's all in how it's done. They could probably do a lot of evidence-based medicine with the National Healthcare Program, but they can also do it with private programs. Group Health, Kaiser, they do amazing things. So I think it's all in how it's done. And again, I'm not the expert in that. I just see it on the ground level. I don't know if you guys want to comment on that.
Yeah, I'll comment on that. Actually, I think having a unified healthcare system would do a lot towards being able to implement evidence-based healthcare more effectively. I think there's a couple of instances that we can look to. For example, Germany, which doesn't actually have a single payer system, they have a very regulated system of competing health insurers, but it's very regulated. And the amount of money in the system is controlled by a national committee. They implemented almost immediately a set of standards around chronic care management. And they were able to do that because they held both the purse and the regulatory power over all of the plans. Now compare that with, you mentioned Group Health does great things, and they did when they existed. And they did. And they had probably one of the world's most well-known researchers around chronic care, Ed Wagner. And yet, Group Health didn't own the Seattle market. It because they were so good. They didn't own the Western Washington market because they were so good. Okay, because the fragmentation of the system, the incentives actually are to avoid people who need chronic care. So I think a unified system would do a lot towards being able to promote what we know to be the most effective and efficient services.
We have time for 2 more questions as we are a little bit over time. Yes?
Yeah, just actually a follow-up on that question that gets to not only evaluation of care, but the issue of the value of a single integrated electronic system with longitudinal studies of a population-based epidemiology has enormous potentials for preventive medicine. So my question to Dr. Basu, any of your colleagues in health economics looked at some evidence that turns that into what might be some potential savings? An example might be to look at what happened when the Veterans Administration, our single-payer system, they were the first guys to really get into regulation of blood pressure. And that had enormous impact on cardiovascular disease, for example, probably on some CNS disease. So what's going on in your field in that?
I would agree that there is tremendous value of lifetime longitudinal data on epidemiology, health status over time. You know, we look to VA, we look to Canada, and we look to UK to find those longitudinal studies. Often here in the United States, there is no one single database that captures all of that in one place. The state has an all-payers database now, but it's only claims. It is not connected with all the EMR and the lab data. You know, the Medicare system is separate from the Medicare Advantage system. I mean, CMS is only releasing Medicare Advantage right now. The private system. So there's a highly fragmented that creates a lot of problems in research. But I think in this case, although research has tremendous value, the key here is actually providing the right healthcare for the patients that are currently in the system. And it goes beyond, like, what we can learn from having an integrated system. Again, one of the value of national healthcare system that we would have such an integrated system, right? And we can study that. But and nobody would say that that's not the case. The key is how do we get there? I mean, can we really get there? Especially when we see a Medicare system that would not when they provide these evidence-based coverage guidance, that would not look at costs. That would say, well, this lung cancer treatment, increases life by 3 months, and even if it costs, $250,000 a year, it's covered. Right? And the question is, every other system in this world that has national healthcare system would not allow that. So the question is, you cannot have both sides of the coin. You have to give up somewhere. So you talk about prior authorization, you talk about drug prices. But each of them would be still there under the national healthcare system. The national healthcare system just cannot pay for everything that comes up. Right? No. But they do now.
Because our politicians won't let them. They can cap drug prices.
Well, why don't we do it now?
Because the system's corrupt. You can fight it. We can
I agree. I mean, that's what we are fighting for, right? That's what we are saying, that we are doing, all these cost effectiveness, we are producing this information out there, and we are agreeing that, the public system should account for that, and have a more efficient system. What I'm saying is that it becomes much more easier to transition into a national healthcare system if we have much more efficiency in that sense. If you get rid of the corruption, if you get rid of more value-based care, it's even more easier to transition into a healthcare system, a national healthcare system.
Thank you, Dr. Basu. We have time for one more question.
This, I guess, is the Dr. Basu, whoever wants to get through also. But what do you feel is the main impediment to the U.S. obtaining similar costs as a percentage of our GDP, and also improving our health outcomes industries have been able to do?
So the main impediment for actually reducing cost and improving outcomes. Well,
How can we do it better? As-
yeah, well, I think there are a lot of nuances to it. So let's take the pharmaceutical industry, which we work a lot with. We evaluate a lot of their products. U.S. is the only country in the world that allows free pricing of pharmaceutical products. Right? U.S. is also the only country in the world that 50% of innovation of pharmaceutical drugs come out of. Right? So the question is, where do you draw the line? Right? How much leeway should you give a private industry? So what is the trade-off between what's the right level of innovation versus what's the right level of actually, allowing profits to happen, right? And that's where the tension arises. We can negotiate the prices and bring down the prices all the way to pharmaceutical companies. Right? Would the next Sovaldi come out in the next 10 years? We don't know that. We have to see. What we have found is that when Medicare expanded Part D, which is covering prescription drugs for all elderly people, pharmaceutical company did come to the market with more number of products because they were, but for per product, the returns, the health returns, in terms of survival, was much lower than it was before. So we show that the returns was lower when such happens. So there's always a trade-off, and so we cannot totally eliminate that industry, but we can also not let them free price and get whatever profits that they get. And that's why we need more understanding about value within the system. And I must say, in the US, the public payer is the most reluctant to discuss value. ACA has specific language saying that we shouldn't look for cost per benefit criteria to set any reimbursement criteria.
It's a political problem.
Well, everything is a political problem.
Thank you, Dr. Basu. Join me in, again, giving a round of applause to all our speakers today.